Okay. So for those of you who are in the other group, again, my name is Tamrah. I'm one of the instructors. We're going to talk about central venous access devices, CVADs. And as you can see by this initial picture, there's a lot of different access points. And I just want you to be aware of all the different veins that can be accessed for central circulation. Okay. And this is going to be loaded up so you guys can pull this off of your, I think she's putting it in Blackboard, right?
Yeah.
So you'll be able to see this. But there's a lot of different places that you can have a central line. It's not just, one or two places. So the objectives here, just to be able to identify the catheter and the tip location. You want to know what kind of catheter you have. How are you going to be, as the nurse, assisting the physician in placing these? And there are certain nurses that actually put these in. I used to be a PIC nurse, put PICs in myself, and I do put midlines in now. How do you pull blood off, give medications through a central line, how to take care of them, change the dressings, and complications that can arise with central lines. Now, central lines cover a lot of different types of lines. Arterial lines are central lines, but we're not going to be talking about arterial lines today. We're talking just about venous access devices. So tunneled catheters, non-tunneled catheters, PICs, and ports are all considered central lines. And then we have this, what are called midlines. They're technically a peripheral IV, but they can stay in for up to 29 days. So they're kind of a gray area in terms of lines. We'll talk about those as well. So you have a lot of different types of central lines or venous access devices that are available. Why do we need a central line? This guy is a heroin user, and this is a really good example of why you might need a central line, because his veins are probably shot. He's probably destroyed all of his veins and has no peripheral access. So somebody like this, people who are on chemotherapy are going to need long-term treatment, TPN, hemodialysis. If you need rapid fluid resuscitation, somebody who's been in a car accident or has bled out rapidly, a big bore central venous access device to get fluid in quickly. Antibiotics, there are certain antibiotics that you really don't want to put through a peripheral IV because they're caustic to the veins. And if you want to do any kind of pressure monitoring, any cardiovascular pressure monitoring, you need a central line for that. If you have just a little old lady, if you're 93 years old, your veins are 93 years old. And sometimes their veins are very friable and you just cannot get a peripheral IV in, and so they will go to a central line or a midline. Blood transfusions, lab draws, if they don't have good peripheral access, they will put a central line in as well. So central venous catheters, aka central venous access devices, aka central lines. You may hear all these different terms used or see them written. They all kind of mean the same thing, but remember, an arterial line is actually a central line as well, but it's not a venous access, it's arterial. So your central venous access devices, the tip of them ends up in the superior vena cava. Sometimes they will, like PIC lines will sometimes actually go into the atria, but just barely into the atria. And this is important to realize that these are here in this big vein where there's high flow, so the medication is getting diluted very quickly. So if I put in vancomycin down here in a little peripheral, I've got this little tiny flow going through a peripheral vein, but if I'm dumping it into this big superior vena cava, that drug is getting diluted very quickly, so it's not caustic. Does that make sense? Mm-hmm. So that's why these big veins are really good to have. These central lines are good to have for certain medications. A lot of times they're kept in short term. If you have a person who has acute kidney failure, and they're going to be on dialysis for a short amount of time, they may put in a central line just so they can do hemodialysis until their kidney function returns. Oftentimes they're in only for maybe a month, and then they'll take them out once their treatment is completed. And they can be used for any kind of solution, but central lines can be kept in for a longer period of time, and PIC lines can actually stay in for a year, and ports can stay in for years. And I've had patients who've had ports for like 10 years, the same port. And if it's cared for really well, it's flushed regularly, it's heparinized appropriately, they can stay in for a very long time and continue to work and function. And that's really, really a plus for the patients who are going through treatments, and they don't have to get stuck over and over again with these peripheral IVs. anything can go through these lines. You can put TPN, you can put chemotherapy, blood, anything can go through them, whereas a peripheral IV, you can't. All of these lines need an x-ray after they're placed to ensure that they are in the proper location, and they usually put these lines in either in surgery or in an interventional radiology suite where they are actually under an x-ray, and they will get a film done. If they don't do it there, they will have a portable chest x-ray usually done afterwards to confirm that these are placed in the correct location. And they are all put in by sterile technique because remember, you're accessing central circulation. So if a little bug gets right in that central vein, it's going right to the heart. So it's really, really important that all of your techniques are very sterile when these are being put in, and that when you're doing your dressing changes that you use sterile technique as well to prevent any kind of an infection. Central lines have one of the highest infection rates, and they're very closely watched. These rates are watched in the hospitals. They're called CLABSI, central line associated blood, excuse me, bloodstream infections. So let's talk about tunneled catheters. Tunneled catheters are one type of catheter that are put in, and they're actually, a portion of it's tunneled underneath the skin. And it exits on the chest, and the distal third is in the superior vena cava, just like all your central lines are in the superior vena cava. They don't have a specific dwell time. They can last for several years. They're usually not in for more than a year, usually not in for more than a few months, but they can be in for a much longer time. Again, used for all solutions. They're put in surgery or in interventional radiology. And again, x-ray is necessary to verify that they are placed appropriately. So this kind of shows you a tunneled catheter. You can see number 1, that's where it's actually accessing the vein, and it goes down into the superior vena cava. 2 is the tunneling underneath the skin, and you can sometimes actually feel that little cord. And then 3 is where it's coming out of the skin, and that's where your access would be. You'd see the port sticking out there. If you have a port, the ports are placed in the chest here, and they run up into the neck, and you'll often see the line or the tubing underneath the skin. So just so you know what that is, and the patient knows what it is, it's just tunneled underneath the skin. You have 3 different types of tunneled catheters. A Hickman, which is the one you'll probably see the most. These are often used for people who need dialysis. Broviac, which is kind of like a Hickman, it's just a smaller catheter, often used in pediatrics. And then you have a Grochon, which has a valve tip on it. The Hickman and the Broviac are not valve tipped. The Grochon is. So when you go to pull back, say I'm going to draw blood out, I want to do some labs. I aspirate. It creates negative pressure. You can see the little valve. Little valve opens in, allowing you to pull blood into the line and out into your syringe. And then if you're pushing medication or you're flushing it, the valve kind of opens up, allowing that medication or flush to exit the end of that catheter, and then it just stays closed. These particular catheters, the Hickman and the Broviac, they both have clamps on them. Your Grochons do not have a clamp. All of your central lines, when you are not using them, need to stay clamped. But the Grochon does not have a clamp on it, so you can't clamp it. It doesn't need it. Tunnel catheters also have what is called a cuff. I'm going to pass this around so you guys can see it. This is a little Dacron cuff on here. So right here, on this side right here, you'll see the little cuff right at the very top, right as it kind of enters the skin. So you've got, this one's a double lumen. It's got 2 ports, and then it'll go underneath the skin, and just below the skin, you'll have the little cuff. And what the cuff does is it allows granulous tissue to infuse into it, and it kind of helps it stay in place. So the skin kind of, in a sense, your tissue kind of heals into it, keeping it in place. What that does is it allows a barrier, it creates kind of a barrier so that infection is at a reduced risk, so infection can't follow that line in, because that cuff is there. You've got that barrier that it's created. So let's talk a little bit about ports. Has anybody seen a port? A couple of you guys? Ports are usually put in interventional radiology. You'll see these mostly in patients who have chemotherapy being performed. My mother-in-law actually just got one of these in. She's getting ready to start chemotherapy this week for breast cancer. They're great devices. They can stay in for years, and they look like a little button underneath the skin. They're very easy to draw blood from. You can put any kind of medication, chemo drugs. A lot of times patients on chemotherapy need blood transfusions, and so, or platelets or whatever, and you can give blood through these particular ports. Again, sterile technique when they're placed in IR, and then you have to have special training to access these. It's not, they're not already able to be accessed because they're underneath the skin. You have to use a special needle called a Huber needle. And if you can see right here, it's kind of shaped like a little, like this. Can you guys see that? And you have to go down and actually hit the bottom of the port when you put the needle in, and then you can draw back. There's like a little well inside of there, and then the little well beside, you'll see the port is like this. It has like a little well underneath, and then there's a little side port that the tubing comes out, and then it goes into this SVC. And so when your needle goes in there, that's what you're accessing, is that well. These are really, really nice to use, but sometimes when you put those needles in, it can be difficult. Sometimes you hit sideways and you don't get blood back. So you really do have to be trained on how to put these needles in and how to take them out as well. Ports have to be filled with heparin. They have to be heparinized when they're not in use, just like all central lines for the most part. Depending on facility policy, but the ports for sure, and your other regular central lines except for PICCs, they really do need to be heparinized regularly, especially when they're not being used, because you don't want any kind of clotting or buildup of fibrin in the line to prevent them from being able to be used, because you don't want to ruin a port or a central line, have to have it taken out and put a whole new one in again. So you want to make sure that it's able to be flushed appropriately and you can draw back on it. So you will see these. There's different types. Like I said, they're mostly used for patients who are going through chemo. All right, everyone's seen a PICC, right? Okay. So PICCs are peripherally inserted central catheters. These are central lines, but they're inserted in the periphery, and usually in the basilic or the brachial or the cephalic veins in the upper arm. And they're rather long. They start here, and then they go all the way just outside of the heart in the superior vena cava, or in just into the atrium. These can be put in by special trained nurses, or they can be put in IR. And sometimes in IR, it's not just the IR physician, but there's physician assistants that can put these in as well. But you do have to have X-ray to confirm placement on these. A lot of times what happens when these are put in is they'll flip, and they can flip and go up the neck. So you have to have an X-ray to confirm that you've actually gone down into the SVC. When these are put in again, same thing, maximum sterile barrier. It's really important to keep sterility. One of the things you see a lot of times with PICCs, and sometimes other central lines, but PICCs I think probably more often are what you hear about, are DVTs forming. Have you guys heard of DVTs in the upper arm from PICC placement? These PICCs have maybe been in for a while, and so the patient may develop a deep vein thrombosis in the upper arm. You start to notice swelling, redness in the arm. So PICCs, again, central line, anything can go through them. TPN, blood, you can draw blood from them. And again, they just need to be really taken good care of, because they can stay in for up to a year. All right, midlines. Anybody seen a midline? Nobody? So some facilities have what's called an IV access team or a PICC team, and I used to be on the PICC team. But what they've done is they've, for the most part, taken PICCs, and they've just had the IR staff and the IR physicians put them in. But there are still nurses who do midlines at bedside. Now, midlines are a peripheral IV that is placed similar to a PICC, and they use a partial sterile barrier, meaning you don't cover the entire body with a sterile drape. You cover just basically the arm that you're working on. The nurse that's putting these in still wears a sterile gown, sterile cap, sterile mask, sterile gloves for insertion, just like you would for a regular PICC line or any central line. These are placed in the forearm. They prefer the middle third of the forearm, of the upper arm. You cannot put anything in these lines. These are placed for long-term treatment. They can stay in for 29 days. So if a peripheral IV, you're having a really hard time getting a peripheral IV in somebody, and you know the patient's going to be in the hospital for some length of time, then a midline might be a good option. A lot of times these patients get really, really tired of being stuck over and over and over again. Their IVs keep blowing on them. And so a midline is a good option because those deep veins that kind of run near the bone, the basilic especially is a very large vein. It tolerates high flow pretty well if you have a lot of fluid to give or blood to give. So they're put in by ultrasound. You have to have an ultrasound machine to locate the vein and watch the needle going in as you actually place the catheter in. But remember, this is a peripheral, and they usually are marked very well with bright orange stickers that say midline, not a central line, all over the place. And you'll even see a sign behind the bed because a lot of people confuse these with PICCs. And it's important to recognize that they're not central lines. They're kind of in the middle between a central and a peripheral. The beauty of these, again, being that you can have them in for up to a month. They're not always able to be used for blood draws. If they're flushed really well and you keep flushing them appropriately, sometimes you can get good blood back. But if you have a patient with a midline and you need to have labs, you may not necessarily be able to get blood out of a midline. They do over time. They kind of collapse in, or depending on what vein they're in, when you go to pull back, the vein may collapse down. So you may or may not be able to get blood out of them. If you can't get blood but it's flushing well, don't be alarmed by that if it's a midline. If it's a PICC, it's a problem. If it's a central line, it's a problem. You always should be able to get blood back out of those. But midlines, you may or may not be able to. The longer they're in, the harder they are to get blood back from. Okay. All right, medications can irritate veins, and they often need a central line. Unless you're doing just really short therapy. Sometimes you can tolerate for a very short amount of time, like Vanco for just a couple doses, but after that you really do need a central line for those medications. Certain drugs, no matter what, are just irritating to the veins, regardless of whether they have a high or low pH or their concentration, and they need a PICC or a central venous catheter when possible. Infusion Nurses Society standards of practice recommend that if you have a pH of less than 5 or greater than 9, then it really should be infused through a central line. So PPN, TPN, Vanco, of course, is a big one that you see a lot, doxycycline, Cipro, all your chemo drugs, those all really need to be going through central lines ideally. You'll see them going through peripheral, some of them, not all of them. Like you would very rarely see chemo going through a peripheral IV, but Vanco you may see through a peripheral for just a few doses. So don't be alarmed by that. But if your patient's going to be on long-term vancomycin, you would want to suggest to the physician that the patient get a central line, probably a PICC, because they might be going home with that medication, and the PICCs can go home with patients. Midlines can go home with patients. So just be aware of that. Okay, everybody still awake? All right, just making sure. All right. All right, central venous access device insertion. This is usually done at bedside or in radiology or in the OR. These can be done especially at bedside in the ICU or in the ER. When I worked in ICU, we would have central lines put in at bedside frequently. And then if you're a PICC nurse and you have a PICC team at your facility, then the PICC lines are done at bedside all the time, especially in the ICU setting, or patients are brought down to your unit and you put them in while the patient's laying on a gurney. They do have to be put in by trained doctors or physician assistants. It is a sterile procedure. And if the doctor is going to put in a central line at bedside, as the nurse, it's your responsibility to make sure that you keep everything sterile, that you recognize that everything in blue is sterile. You don't want to corrupt the sterile field. You don't want the patient to corrupt the sterile field. So what I tell patients to do is keep their hands by their side. Don't bring your hand up. A lot of times they want to reach up and scratch their nose, or they want to reach over and scratch an itch somewhere. Just tell them to keep their arms down, because if they come out from underneath that blue, they've contaminated the sterile field. You have to wear a gown, a sterile gown, sterile gloves, sterile mask during insertion. You want to maintain sterility, and chlorhexidine is used to clean the site that it's going to be placed in. Consents, you don't need a consent for PICC lines anymore. You'll have to find out from your facility whether you need a consent form for a central line. It may vary from facility to facility. What you do need, though, is a doctor's order. So before you call a nurse like myself to put a midline in, before you call IR to have a PICC line put in, make sure, you don't need an order for a PICC line, but make sure you have a doctor's order. I mean, you don't need a consent, but you do need an order, okay? Now, medication prior to procedure, they may medicate a patient to keep them calm for a central line placement, like if it's going to be a tunneled catheter, because that would be painful. Ports, absolutely. They use some Versed and fentanyl to sedate those patients for that procedure. PICCs and midlines, it's just lidocaine, just local, just numb up the area. It's like a bee sting, and then the access is made. So what you may be asked if your physician is wanting to put a central line in at bedside, or if you're working in the ED or ICU at some point and you need to have one of these placed, is you're going to need a central line insertion kit. And in those kits, usually everything comes that you need. But if they don't have everything, find out what you have in that kit, because you may need to go get sterile gloves. And the doctors usually will tell you, hey, I wear a glove size 8, or I wear a glove size 7.5, or something like that. So ask the doctor what the glove size is that they need. And if you need sterile gloves, get your glove size as well, because he may need you to hold something or grab something quick. And then you may have to get a sterile gown, sterile mask, or not a sterile mask, but a mask. But the gown is sterile and the gloves are sterile. And then a hair bonnet to protect and keep your hair out of the way. Lidocaine oftentimes comes in the kit. It's 1% lidocaine that is used, typically. And then if you're going to do a dressing kit, just a dressing change kit, it's you don't need lidocaine for a dressing change. But in the insertion kits, there's lidocaine, there's needles, there's syringes. There should be everything you need, and you can read on the outside of the kit what is available. And I think they've got one here. I'll pass this around so you guys can take a look at this. A towel roll, sometimes they put a towel underneath the shoulder. If they're going to go in on this side, they'll put a towel underneath the shoulder to kind of bring that side up a little bit. It makes it for a little bit easier access for the physician. And then you may need to put the patient in Trendelenburg. What is Trendelenburg? Head down. Head down, feet up. Yeah, so it's like this with their head down. And then you want to monitor your patient when these are being placed in. So usually you do Q5 vitals while they're being placed to make sure that they're okay. So once this is placed in, you want to make sure you know what the flushing protocol is for your facility. We'll talk a little bit about syringe selection and PCI, which is pounds per square inch. That's talking about pressures. Extension sets and cap changing, dressing changes, blood sample collection, and then insertion complications that can occur, what to recognize, what to look for, when to call the physician. So let's talk for a minute about flushing. You can never, please understand this and hear me, do not use anything less than a 10 milliliter syringe on any central line. Okay, make sure. If you go to flush with a 5 ml syringe or a 3 ml syringe, the pressure is too high and you could potentially rupture the catheter. So only 10 ml syringes or higher. In terms of heparin, midlines you don't usually heparinize. PICCs, it depends on your facility. You may heparinize it if it's not being infused. And if it's just sitting there, not really being used. And it would be just 3 mLs, 100 units per ml. For a PICC line, a CVC, a Hickman, or a Broviac. Ports, however, you need 5 mLs, 500 units per ml. So how many units is that total we're giving? 500, right? So you want to make sure you have the appropriate heparin that you're going to be using for the line that you're using. And then for frequency of flushing with heparin, after each time you access it, if it's locked, meaning there's nothing infusing, if you access the vessel or actually access the port to give some medication and you're hooking it back up to normal saline or D5W or whatever, then you don't have to heparinize it because you've got it infusing. And then ports, if they're infusing, you don't have to heparinize them. But if they're not, and a lot of these patients will have chemo treatments once a month. They'll go in, get their chemo. After the chemo treatment's done, they flush it, they heparin lock it. They're good for a month, and that heparin just stays in there. But if their next treatment is not for a month and a half or 2 months, they may have to go back and have it heparinized again and flushed again. Okay, so if you take good care of your central lines, keep them heparinized appropriately, keep them flushed appropriately, they'll stay open for you and continue to work for a very long time. All right, SASH. Everyone's heard of SASH? All right, SASH is really important. So I have a medication, let's just say I have a central line, and I've got some D5W infusing, and I need to give some medication, IV push. And I don't know if this is going to be compatible with my D5W or not. So you want to make sure that you're flushing something that's compatible with whatever else is in the line, right? So we have to first flush with saline to get one, if it's been locked and there's heparin in there, you need to get the heparin out. But if it's infusing with, say, D5W or anything else, you want to flush it with normal saline to get that out of that line. Okay, so that's your, that's your S, saline. Then you're going to administer whatever medication you want to be giving. So maybe you're going to give them some morphine or some other antibiotic. You administer that medication, you push that in. Then you're going to give some more saline to flush the medication out of the line. Then you can hook them back up to their medication that their maintenance IV. Or if they're just heparin locked, then you put your heparin in. And again, for ports, it would be, anybody remember? 500. If it was a PIC or some other central line, it would be, right. So that's your SASH, saline, administration of medication, another saline flush, and then heparin lock them. But again, if you're going to have a continuous IV infusing, then you don't add the heparin. You just go ahead and hook them back up to the infusion. So this is called, can you wait until the end? So this is the different flow characteristics. You have laminar flow, which would be like a slow push. And then we have what's called turbulent flow. And when you're flushing these, it needs to be a stop-start. Have you guys heard of that before? The stop-start for flushing? With central lines, it really needs to be push, pause, push, pause, push, pause, all the way through your 10 mLs of saline. And it's really important that this is not a gentle, it needs to be a forceful, turbulent type of flow, because on the tip of these catheters, you can get these fibrin sheaths starting to form, and you want to flush all that off of there so that you don't develop a clot on the end of your line. So you want a nice, strong push, pause, push, pause, push, pause, push, pause for every central line that you have when you're flushing it. So let's talk for a minute about your syringe selection. We already talked about you don't go any lower than what? 10 mLs, always. And you can see that the difference in the pressure increases with your 3 ml syringe, see 48 versus 18. So it's really important that, especially like when you're pushing meds in, when you're withdrawing, you really want to use a 10 ml syringe or greater. Extension caps are changed with every tubing change. You want to use aseptic technique, and they need to have the lure lock, you know, the top you screw on the extension or the tubing on the top of it. You never clamp. You don't ever use scissors or hemostats on these because you can, on the lines themselves, because you can damage them. And you don't want any kind of plastic or, it's not plastic, but you don't want any of that material breaking off. So always use aseptic technique, alcohol swab the top of your caps, and when you're ever giving an infusion or pushing any medication into it, or connecting it to an extension set. All right, dressing changes. I didn't know it was going to do this. The two functions for dressing changes. You want to provide a protective environment for the catheter. You want to keep it as bacteria-free as possible so that you don't have an infection. And it helps to prevent catheter migration and dislodgement. A lot of these lines, central lines like your Groshong or your Hickman lines, the tunnel lines. The tunneling itself helps to keep it in place, but sometimes your central lines, other central lines that they may put in, they'll suture them in place. But the dressing itself will oftentimes help to kind of keep it from migrating. And we don't want it to migrate because it could migrate out, which we don't want, or it could migrate further in, which we don't want, because you may have collateral circulation in there and it could go down one of those little collaterals or down into the actual atria of the heart. So they have central line dressing kits that are sterile, and you want to make sure that you don't have to gown up for this, but you do have to wear sterile gloves and a mask. And then you're going to use chlorhexidine. You can see the chlorhexidine up there. And then you're going to clean the area. How do we clean? Does anybody remember how you clean central? Yeah, it's back and forth, back and forth. Yeah, start in the center, go out, back and forth across the entire site. It used to be around and out, but now it's just back and forth on your sites. They need to be changed at least every 7 days, unless it's draining a lot and the dressing has become compromised. So it's every 7 days or PRN. And you want to look at your facility. Some facilities say every Monday is central line dressing change day. Every Wednesday is central line dressing change day. So know what your facility's policies are. So again, sterile gloves, always wear a mask, use a ChloraPrep to clean around that site. Do not use any microbial or antibacterial ointment except for on hemodialysis catheters, okay? So PICC lines, those kinds of things you wouldn't use. And this is important to know too, because your patients are going home a lot of times with these central lines. So if I have a patient who's going home with a PICC line, they may go, oh, I don't want to get an infection. I've heard these infections are horrible. I'm going to put a little Neosporin around that site. Don't tell them not to do that. What is this thing called? Anybody know what that is? BioPatch, yeah. So biopatches have been demonstrated to really help reduce infection risks. So when you're changing your dressings, the first thing you do after you've cleaned the site is put a biopatch around the insertion site. And you wipe back and forth, like we talked about, for 30 seconds and let it air dry. Apply your biopatch, then apply your transparent dressing. What is that called, the transparent dressing? A Tegader. And then you always want to date, time, and initial, and then document that you did the dressing change, because if you don't chart it, it wasn't done. PICC dressing changes. There's a StatLock securement device that when you're doing your dressing changes, you want to change that as well. You have to be very careful because PICCs are not secured. If you pull it out of this StatLock, there's nothing holding that PICC in there. So you have to be very careful that you don't pull that PICC line out. I've seen that happen. Pull your transparent dressing by stretching it outward, and that will help to prevent you from possibly dislodging that PICC line. Apply alcohol. That kind of helps to remove the pad around the edges here. That white stuff is a little bit like foam adhesive, and that pulls it off a little bit easier when you use alcohol. It also helps to defat the skin so that when you're putting the new dressing on, it sticks a little bit better. Put the new StatLock device on. Put your PICC in it, secure it in, and then you put your transparent dressing on that. A lot of places are using biopatches on PICC lines now as well at the insertion site, so be aware of that. And again, date and initial, so the next person knows when the last time that dressing change was made. And then again, last thing, always document it. All right, let's talk about drawing blood off of these. Oh, all these little things here. So if you're going to draw blood, the first thing you need to do is stop all infusions. You don't want anything infusing when you're trying to draw blood off. So you have to stop. Then you have to flush the line with 10 mLs of normal saline. And that's to get that medication or whatever was infusing out of that line. Then you have to aspirate 3 to 6 mLs of blood and throw it away. This is called waste. We waste 3 to 6 mLs of blood, and you just throw it away. And then you draw up however much blood you need for your lab. Some people use a 10 ml syringe. They just Luer lock it on, draw back 10 mLs, unluer lock it. Some people use a vacutainer, and then just you can put your lab vial on the vacutainer, and the blood will just come out and fill up the vial. But when you're done, you really need to make sure you flush that lumen before you restart your solution to get that blood out of there, because you've got all this blood now that's come up through the line. It can adhere to the sides of the wall. You want to flush all that back out. And then again, if it's not going to be used, you heparinize it, heparin lock it. Or if you're going to restart your maintenance IV, restart your maintenance IV after you've given it a good flush. And what kind of flush do we do? Push pause, nice and hard. Do not draw drug levels from a line in which that drug's been infusing. So if I need a vancotroph, I'm not going to draw it from the same port, the same line that I had vanco running through. Makes sense, right? If you can't get a blood sample, and sometimes this happens, you can move your patient side to side. Sometimes these lines get bumped up against the wall of the vessel. You can raise their arm above their head, have them change position, have them cough. Sometimes that helps. Or you can just flush it again with another 10 or 20 mLs of normal saline. But again, always use a 10 ml syringe or higher. So this is your vacutainer here, and you'll see the little piece, the gray piece inside. So you screw that lure lock on, and then you just put your tube inside, and that little gray piece goes into the top of the vial, and the blood just comes out. Or again, you can use a syringe and a transfer needle to put it into the vial as well. Accessing a port, you really need to be specially trained to do this. This is not something you can just learn to do on your own. This is showing you the Huber needle here. It has to go straight through. Some facilities will numb the skin with some lidocaine. Where I worked, we never did. We weren't that nice. Most patients didn't complain of pain. You can choose the size of the gauge of these needles as well, but you'll just notice that's got a covering on it, and you take the covering off and you'll see that it is kind of a funky shaped needle. They can stay in for a long time as well, for a couple days. The needles can, but the ports can stay in again for years. So they're very nice to have. Oh, there's my dog. We're almost there. This is Murphy. He needs some dental work. He just wanted to tell you that you're almost done. All right, post-insertion complications. You can get mechanical phlebitis, chemical or bacterial phlebitis, exit site infections, bloodstream infections. The catheters can fracture. It's very not a common thing to see. I've never seen a catheter fracture, but apparently it's happened somewhere, sometime at some point in history. Catheters can be occluded, obviously, thrombosis, they can migrate. And if they migrate, or if you have a catheter fracture, or you get air into these central lines, because remember, these are going right into the heart, right? You get a pretty good amount of air in there, that can cause an air embolism. Or if you have a fracture, you could potentially cut off blood flow to the lungs, and you can have what's called a noxic encephalopathy, which is an absolute emergency. Anybody ever had phlebitis before? No? I had it once in a little vein here on my arm. I gotta tell you, it really hurts. It really does hurt. And it was, you could actually feel the vein. It went from here up to about here on my arm. And it was really red, really swollen, very tender. And you could actually see where, like, just the outline of my vein all the way up to that point. So it's very, very painful. So phlebitis just means what? Inflammation. Inflammation of the vein is what we're talking about specifically here. So if you start to see this, let the physician know that the patient has phlebitis. They may or may not want to stop it. Usually you will need to take that line out and put a new one in. That pain or tenderness, you may have some drainage. You can have redness around the site. You can feel the venous cord. I had that. It's very tender. And you can get some swelling. So it's kind of hard to see in this light, but maybe you may be able to see this better once it's up online. So you can have some irritation of the vein from chemotherapy, from placing the line itself. If you imagine, I'm putting this, I've got this tube, which is my blood vessel, and I'm putting this catheter in, and as I go in, if I put it in too deep and I scrape along the wall of the vessel as I'm placing that catheter, you can cause phlebitis from that. Some irritation, mechanical phlebitis. Catheter material and size can be part of the cause. The skill of the inserter, again, if you're scraping along the wall. Where the tip is located, it can be irritating. So lots of different factors. What do? Notify the physician and immediately begin some treatment. They may probably want you to take it out. Some moist heat, elevate it. You can move the arm around, non-steroidals, Symptoms usually do resolve fairly quickly depending on the severity. Exit site infection. This doesn't show up very good on here, but it's kind of a really ugly infection at the site there. So if you notice that the site is becoming very red, tender, they've got some drainage, pussy drainage especially. They may not necessarily have a fever or elevated white blood cell count, but it's very tender and you can actually see a lot of, some exudate, and you can tell that it doesn't look good at the site. It's real red and angry looking. In those situations, that probably needs to come out, and a lot of times they'll have you culture that site as well. I've seen ports that have been infected, port pockets that have been infected, and they can get really, really gnarly where they actually have to pack them, and they have to be on antibiotics for a really long time, which is really a shame because those ports are nice to have, and now they have to take it out because you can't leave an infected port in. Lots of causes for infection, but the main cause is just improper skin preparation and not using sterile technique. So we can't really push hard enough the importance of using good sterile technique when handling any central line or even a midline, and using aseptic technique when you're accessing these vessels. So if you think that the patient has an infection, you want to make sure you notify the physician right away. They probably are going to have to take that out and put them on some kind of antibiotics. All right, CLABSI, a really big deal in the hospitals. The hospitals all monitor the rates of their CLABSIs, catheter-associated bloodstream infections. So if you're gonna, this is basically like sepsis, right? They've got bacteria now in their bloodstream. So fever, chills, elevated temperature, blood cultures come back positive. They may be they're septic. So if you suspect this, the line has to come out. They oftentimes will culture the tip. But these are really important to recognize the signs and symptoms of CLABSI. And you really want to reduce your risk. And the best way to reduce your risk is by using sterile technique and good aseptic technique. All right, causes. The more lumens you have, the more access points you have for bacteria. Fibrin sheath, which is the fibrin that can form on the end of the line. Patient condition, if they're immune compromised already, they may not be able to fight off any little small amount of bacteria that's getting in there. The catheter material. What's the insertion site? If I have a line in the groin, in the femoral vein, versus up here, which area is more dirty? Down here, right? So this is maybe at a higher risk of getting infected than, say, something up where it's maybe a little bit cleaner. Even though it should be covered, it's still, you've got sweating going on and so on. Are you using good aseptic technique? Are you washing your hands? And again, strict adherence to sterile and aseptic techniques. I cannot stress how important this is when you're dealing with these lines. What do you do? Again, notify the physician. Culture it. And then you may or may not have to probably going to have to take that line out. So the Institute for Healthcare Improvement, they want you to bundle together these things to keep this patient safe. Hand wash, maximum barrier precautions, chlorhexidine. Make sure you're using a good chlorhexidine when you're cleaning or changing the dressings. Catheter selection. Look at your lines every day. You should be assessing your IVs as part of your assessment in the morning right away. I've caught lots of things first thing in the morning that the night shift might not have seen because it might not have happened when they first did their assessment, but you should be continually, especially if your patient has a central line, you should be continually assessing that line throughout your shift. It shouldn't just be a one and done kind of a situation. You should be looking at that line frequently to make sure that it's still patent and not becoming infected or no issues with it. CLABSI is such a big deal because it costs a lot to care for. Now, if you think about, there's 15 million central venous catheter days. That's how many days CVCs are in the United States. And the average rate of infection is 5.3 per 1,000 catheter days, which you think, well, that's really not that bad. But if you get one, it's pretty bad. And it costs a lot of money. That's the problem. They estimate about 80,000 CLABSIs happen per year. And it's $34,000 to $56,000 per episode to treat one of these. It's really a big deal. And this is why the hospitals really want to keep their CLABSI rates down. If you get a CLABSI, there is a 4 to 20% chance that there could be a major issue in mortality. So, you know, it's a big deal because it's sepsis. So you have to be very careful with these and try to prevent them. Catheter fracture, not very common. I've never seen one of these. Have you ever seen one of these, Jana?
No.
Yeah, I've never seen one, but the tip can fracture. It may not break completely. Have you seen one?
Well, in interventional, we retrieve them.
Oh, really? Yeah, I never saw one. They don't have to necessarily break all the way off. You can have a piece, you know, a little piece can come off. So you can get a fracture. You can have blood leakage or fluid leakage. Embolism, same signs as an embolism. Any kind of an embolism is something moving and blocking off. So if it's moved and it's blocked off in the lung, your patient's going to be very anxious, short of breath, have pallor, maybe have chest pain. There may be some pain, redness, or swelling at the site of infusion as well. So what causes it? Improper catheter repair, forceful flushing. This is why we don't use anything smaller than a 10 ml syringe. Didn't secure it appropriately. Damage to the catheter body somehow. Pressure injectors. Where do you get pressure injectors? Where are they pressure injecting these things? CT. Usually you see them in CT. If they go for a scan with contrast, they'll give a power injection. Never force flush them. So we'll talk in a minute about what to look for, but if you have a catheter that's not flushing, you don't want to push it because you could potentially cause a catheter fracture or an embolism or thrombus to break off. 10 cc syringes, secure the catheter. Don't suture or tape over the catheter body itself. Okay. What do you do if you suspect a catheter fracture? This is an emergency. You need to let the doctor know right away. Put direct pressure over the catheter body, and that's to prevent any migration of the potential fracture piece. Let the physician know, obviously. Identify the location if you are able to. And you're not going to be retrieving the catheter fragment. This wouldn't be something you'd do, but it needs to be retrieved so it doesn't float downstream. All right, catheter occlusions. So how do I know my catheter is occluded? Because I feel resistance. When I go to flush or I go to put my maintenance IV up, it keeps beeping. So you've got resistance when you're trying to flush or put medication through your catheter. You can't aspirate blood. That's another major issue. Some catheters you can flush, but you can't aspirate back. And that's not okay for a central line. The midlines, that might happen. You can't aspirate blood. We talked about that earlier. But for central lines, you need to be able to withdraw blood. So if you see in this first picture over here, you see that little tail that's kind of hanging out? Imagine that when you go to pull back, that little tail, what can happen is the little tail can flop over. And so you can't get blood back out. But when you flush, it opens up and you can flush out. But the risk of flushing and flushing hard is that you can break that off, potentially. And then over here you have a complete occlusion, so that obviously you can't flush or withdraw from. Signs and symptoms of occlusion: fibrin sheath, you can't infuse it, can't aspirate, or it's difficult to infuse. Intraluminal clot, inability to infuse, or you have sluggish flow, or you can't aspirate again. So you've got a clot that's built up inside of the actual, not on the outside or the tip, but actually inside. The blood has gotten up inside of the tip of that catheter. So what do? You have to get an order for some medication called Alteplase or Cathflow, and let it dwell inside the line, and that breaks up the blood clot. And you can't do this without, it's not that you have to make sure that it's okay within your policy for you to give this medication. If you're not sure, talk to your charge nurse or find the vascular access team. They can do it. But you just let it dwell for a little while, retest it. If it's still not working, you let it dwell a little longer. So, but just be familiar. You'll hear this name, Cathflow or Alteplase. You'll hear that name. So this is just showing thrombus around the catheter itself. So if you can imagine, I've got this catheter inside my blood vessel. Now I've got all this thrombus building up around it. Blood trying to flow around the catheter is now being impeded because I'm starting to build this like little plug inside that wall. Does that make sense? So a lot of times it's asymptomatic, you don't really notice it, but you can get some swelling, some leaking. You may have a hard time aspirating, again, sluggish flow rates, numbness or tingling in that arm because blood's not able to flow around that clot that's kind of forming on the outside of the vessel. Some tachycardia, shortness of breath when it's more severe. So the catheter material, some of the catheters now are being made with material that does not allow for clot formation, but some of the, clots, blood likes to clot. So catheter material, traumatic insertion, again, scraping along that line, you get these factors forming for clot formation from the injury. If your patient's in a hypercoagulability state, hypertonic solutions. So all these different things are potential causes for thrombus. What can we do to prevent it? Make sure that you have proper tip location, strict care and maintenance, flushing. Low dose anticoagulants, meaning what? Heparin, or if your patient's on Lovenox, something like that. Interventions, what do? Always let your doctor know. I'm not sure what catheter stripping is. What's catheter stripping? Do you know?
Well, they may go in interventional and try and strip that fibrin off.
I've never heard of that. Just take it out and put a new one in, more than likely. Catheter removal, just take it out. If it's not working, take it out, put another one in on the other side. All right, so catheter migration. Catheters can migrate. This is showing probably a PICC line, but see how it's coming and it's going up the neck. So that's not in the correct location. These catheters sometimes can migrate. Either on insertion they go the wrong way, but they should be getting an x-ray like this to make sure they're in the right location. Or over time they can migrate. They can go across instead of down. So what you're going to look for is sluggish flow rates, again, inability to aspirate blood. What's your length? Is it as long on the outside where the insertion site is as it's been, or has it gotten longer? So you should know where it is, and if it looks like it's pulling out. Is it pain when you're getting infusion? Are they short of breath?
Did you talk about the auditory stuff?
Mm-mm. I don't know anything about auditory stuff. What is that?
If it migrates up this way.
Oh, you hear swishing?
You hear
Yeah.
motion sound.
Yeah.
They'll keep telling you there's water running.
If it's up in the neck.
Up in the
Yeah.
Say, somebody, the toilet's running or whatever.
Yeah. Yeah.
You hear water.
All right. So why does migration occur? Vigorous extremity movement. You got a patient who's doing aerobics in bed. Changes in the inner thoracic pressures. Securement has not been appropriate. Maybe the last person who changed the dressing didn't put appropriate securement device on, or maybe it wasn't sutured in place and now it's migrated. Inadvertent partial dislodgement. What does that mean? Patient got up to go use the bathroom and accidentally got it caught. Partly pulled it out. Had one of those the other day. So the best way to prevent catheter migration is just make sure it's secured well, that you have a good dressing on it, and that you inspect it frequently to make sure that it's where it was supposed to be. It hasn't migrated at all. And if you suspect migration, make sure it's working appropriately, let your doctor know, and then always x-ray the tip. Your doctor will have to order an x-ray for it to make sure that it's in the right location. Do not reinsert a migrated catheter. Don't go, oh, look at this PICC is way out here. Let me push it back in. You don't want to be doing that. And again, it may require a whole new line if it has migrated out far enough. And then we're going to end with anoxic encephalopathy. So if you suspect that you have a thrombus that's formed or you have a fracture and that has migrated, you could potentially have anoxic encephalopathy. So it might have migrated into the brain, it might have migrated into the lung, and you've got decrease in oxygen flow. So we have hypoxia, confusion, dyspnea, tachycardia, all the things you would expect if someone had decrease in blood flow to the lungs or oxygenation of the lungs. Nausea, unconsciousness, or death even, which would be the worst case scenario, obviously. There could be a leak. So if you can imagine these lines go in, and if the wall of the vessel itself has somehow broken open and now they're leaking out, a break above the heart, some kind of change in interthoracic pressure or a large air bolus. Bolus must be immediate. Elimination of one cause is preventing, you want to eliminate as many causes as you can. Lure lock connections need to be used. And then if you're doing cap changes or extension set changes, you want to have the patient do the Valsalva to prevent air being pulled in. And then always, again, sterile, airtight, occlusive dressings over the insertion site. So stop the entry of air. When you are removing these lines, do you remember the dressing you used for the chest tube? What was that cause? The Vaseline. Same thing you use for central lines. Not PICC lines, but for central lines, when you're removing them, we use Vaseline gauze to cover the entry site. Put your patient on the left side if you suspect an air embolus. Why?
Because the right lung is larger.
Because air rises.
Yeah, and you keep that air away.
Yeah. And you may also put them on 100% oxygen. Obviously notify the physician right away. Monitor their vitals. They may require aspiration. And the end. All right. That took a little longer. Sorry, guys. All right. Yeah.